I hark back to the launch of the iPhone in 2007 that marked the beginning of the mHealth revolution around the world. The power of the personal computer in the next 5 years or so after then was set to become extremely portable, and the growing penetration of cell phone coverage allowed the world to imagine a future where mobile devices deployed at the bedside in clinics around the rural developing world would change how, what, who, when, and where healthcare would be provided. Despite billions of dollars invested in this dream, this was not to be. We received the first pilot Tata Trust grant to test a hypothesis we had developed to examine this question about why there was such rampant pilotitis. These mHealth tools seem to succeed in small targeted communities, but almost never reach scale. The framework was developed to test the successful integration of digital health tools. And our hypothesis was that it required 3 pillars: task shifting, technology, and training. India did not, will not, and need not have the human resources to staff every primary care clinic with an MBBS doctor trained for 5.5 years. The vast majority of ailments that patients come to in clinics anywhere in the world can usually be taken care of by mid-level providers by following standardized protocols. Patients in the United States are routinely given care by nurse practitioners. India has long-standing success with community health workers chipping away at tasks that were originally the purview of allopathic physicians. Heavily contested court cases in Maharashtra have ruled in favor of community health workers, even giving antibiotics to mothers or children for very specific conditions. In the early decades of the 21st century, information and mobile technology have the opportunity to accelerate this transition manifold. Take, for example, the protocol for chest pain in a tertiary hospital in New York City. A 40-year-old patient presenting with chest pain with no risk factors is offered 2 blood tests, the cardiac troponin 4 hours apart, and 2 EKGs 30 hours apart. If all the tests are normal, the patient goes home. Think about the same scenario in primary care clinics anywhere in the world, especially in resource-constrained settings, where either the unfortunate patient will be given a potion by a quack, or if they present in front of a registered practitioner, they're likely to be referred to the next higher level of care that can sometimes be as many as 8 to 12 hours away. There's no need for this to happen. Troponin is now a point-of-care device that is available at the bedside. EKGs can be done portably and can be read remotely by a cardiologist sitting miles away. What does not happen is an overlap in this Venn diagram of understanding what the real world needs are, what the standard of care is globally, and what technologies are available that can fill this gap. On the flip side, where context is understood, limited experience with design thinking has precluded widely deployed digital health platforms. Public health screening tools, for example, in the analog world, generating endless pages of radio buttons for community health workers to click through, with reams of data generated that do not necessarily see the light of day. Lack of standardization, interoperability, and mandate have generated vast streams of siloed data across vertical programs in the global south, and especially in India. An exploration we did with some Tata Trust funds early in this project, we examined existing data flows in one primary care clinic in Maharashtra, and it showed that there were over 3,800 non-distinct data points being collected by community health workers across 171 different forms and registers. It was in this context that we collaborated with St. John's Research Institute in Bangalore towards systematically imagining and building out the ecosystem for integrating technology and task shifting into primary care in India. There was already ample evidence that both task shifting and technology failed to sustain their benefits if not accompanied by periodic training and feedback loops. Where we have landed up 3 years later, including after the pandemic, or the first phase of the pandemic, is a very different place from where we had intended to go, but the flexibility and the generosity of the Tata Trust grants have allowed us to chart the course we took. In the first year of the grant, we conducted a needs assessment in primary care clinics in urban and rural India through observational studies in government-run primary care centers in Bangalore and Ahmedabad and Bangalore in semi-urban clinics on the outskirts of these cities, and even in the tribal belt of Melghat in Maharashtra, where cell phone penetration and electricity are not reliable. Around the same time, India announced Ayushman Bharat universal health coverage scheme targeting 100 million households of 500 million people. Information technology was expected to be the engine driving the billions of clinical and financial transactions that would follow. In response, at Harvard, we organized a project under the Tata Trust under the India Digital Health Network, with representatives and partnerships with folks from the NCD digital platform in India, Amrit, managed by Piramal Swasth, IMTECO in Gujarat, and technology partners and entrepreneurs from iSpirit and Social Alpha in Bangalore. Before the end of the year, IDHN had provided a substantive 60-page response to the Sri Krishna Commission's Data Protection Bill, focusing on the impact of India's data protection laws in digital healthcare. Our paper, Reimagining Health Data Exchange, essentially laid out the blueprint for what was to then follow from NITI Aayog and the ministries, culminating in the National Digital Health Mission. In year two, we began two work streams, one to start preparing the digital health infrastructure needed to successfully integrate and test these 3T combinations in primary care, and the other to prepare the regulatory and operational infrastructure required to rapidly iterate and systematically test digital health solutions in the public sector for widespread deployment. Our team evaluated ready-to-use open source tools, combining ComCare from ThoughtWorks with ComCare from Damagi with ThoughtWorks' this Bhavni platform to show what this interoperability was really going to look like in India before we started embarking on this national exchange program. For the second week, for the second work stream, and this is, I think, what's exciting and lasting beyond the Tata Trust support, is that we collaborated with NHSRC when Dr. Rajni Vaid was still heading it, with Dell Technologies, with Tata Trust, with the government of Karnataka and the government of India, to designate 10 newly minted health and wellness centers in Karnataka as digital health innovation hubs to rapidly iterate and test digital tools that were being provided to the public sector for widespread deployment. We essentially were looking in year three, as the pandemic was started, at three key contributions to the digital health ecosystem in India. The inclusion, more specifically, of the term machine readable in the Data Protection Bill, which lays out the stage for health data interoperability, the concept of the personal health record as opposed to a hospital-based electronic medical record that helps to, that then becomes the organizing core for India's digital health ecosystem. And finally, the inclusion of regulatory sandboxes in the National Digital Health Mission that allows for a testing environment for the 3T vision. In year three, we finally pivoted because of the pandemic to apply some of these learnings to telemedicine services at St. John's Research Institution for their patients whose care was interrupted because of COVID. Through the pandemic, we've also secured permissions from a variety of national and state organizations to move ahead with a 3-arm quasi-experimental study. The first product that we will be testing is a non-communicable disease platform developed by the government of India and with Dell. The original intent of the grant was to support the generation of livelihoods in innovative sectors in India. Given the growing and acceptance of the private sector solutions plugging into existing public health platforms, largely driven by technology and interoperability, there is certainly massive potential for growth here, not just in the small slice of the startup ecosystem in Bangalore, but in the creation of whole new cadres of task-shifted providers augmented by technology. In 2021, we partnered with a consortium of technology partners to build a pipeline that will feed new apps and digital tools into these digital health innovation hubs. And we hope to build and sustain this over the foreseeable 24 to 48 months.